So what are the combination regimens that are being used now with heterogeneous tumors in patients with that?
Well, I think we don't know what the significance of heterogeneity is, and so a lot of physicians are sort of just factoring this in with all of the other elements that they need to make decisions about how aggressive to be. So I wouldn't say that's a determinant factor, and certainly not more of a determinant about what to do versus someone's performance status or someone's, for example, high volume status where they have a series of bony metastases, more than 4, or they have visceral metastases. Some people think that patients who are symptomatic with metastatic disease, that's really a surrogate marker for, quote, bad disease, because, you know, they have symptoms, meaning they have lots of tumor burden.
Right. I mean, if you have symptoms in my world,
Yeah.
I'm not an oncologist, that's bad disease.
Yes.
It's bad for the patient.
Yes.
Yeah, and again, it's a definitional issue, right?
Yes.
It's bad in terms of tumor progression. That's a technical bad.
Yeah.
Then there's bad because it hurts and it's affecting your life. That's just patient bad.
Exactly.
They often coincide, but they don't always, do they?
No, and it's not easy to know.
So NCCN guidelines have currently, they got no recommendations for the sequencing of the anti-androgens, which is enzalutamide, right? With androgen synthesis inhibitors, abiraterone, pre or post chemotherapy, right? So what is your experience with the sequencing of these agents in CRPC?
Well, I have to tell you, and full confession, as a non-oncologist myself, I deal with this on the policy side, but we do have a very august group of consultants that we use, including one of my colleagues who is a prostate cancer specialist.
Your people.
My people.
So what do your people tell you?
So my people say that there is, again, not enough data to know what to do in the understanding about using abiraterone. See, I can't do it.
I am so glad that tripped you up just once.
So abiraterone is an androgen synthesis inhibitor, and enzalutamide is an anti-androgen capping the androgen receptors on the tumor. Abiraterone has been out for a little bit longer, has a little bit more of a track record, and we recommend monotherapy with abiraterone, and then at some time in the future, the ability to access enzalutamide. But we do not advocate for combination therapy right now because there really is no information. And I think that the level of androgen blockade in the long run, 10 years from now, may not turn out to be as important as answering the question that you asked me earlier, which is, what about tumor heterogeneity, and who might have these gene activation pathways that happen either under pressure or in some people seem to be the more preponderant tumor subtype.
Which brings up the question, right? Can the sequencing of these ADTs result in cross-resistance?
Hard to know. I mean, one thing that I've learned in all of medicine is that if you attack something at multiple steps in a pathway, you tend to be more effective. But it's not always true. And so I think the answer is unknown.
Yeah, my infectious disease colleagues like to say you knock them down and then step on them.
Yes.
2 at once so that you really don't get regrowth. But that's not necessarily true in cancer.
It isn't in all cases. And I do think that there are some situations where trials have been done to look at the patients who are naive in terms of total androgen blockade and hitting them with not just total androgen blockade, but also traditional Taxol-based chemotherapy.
Right. What do we know, by the way, about combining abiraterone and enzalutamide together in CRPC? Do we know anything?
I don't think that there has been anything that is prospective, randomized, and controlled in that arena. It's something that maybe we should answer, and when we answer that, we have to then try to control for other aspects of the disease, such as what is the disease burden, low volume, high volume, what is the performance status of the patient, can we get people at similar Gleason stages, can we get people at similar surgical stages in terms of local invasion outside the capsule, seminal vesicle, lymph nodes. Unfortunately, there are a lot of people in the U.S. who have prostate cancer. And so if we were to take the entire available population, I think we could do that study. However, what we really need are systems for data collection and the enticements to do these trials.
Well, now let's go back just for a moment to talk about second-line, first-line therapy. We've got cabazitaxel. Right? That's out there. It's currently used as a second-line therapy after docetaxel failure. How does cabazitaxel compare with docetaxel as first-line therapy in combination with prednisone?
Well, you know, there is a trial that is ongoing. The trial started enrollment, I believe, 2.5 years ago, and that trial has enrollment closed. The study is ongoing. The primary endpoint in cabazitaxel plus prednisone versus docetaxel plus prednisone is, we don't know the answer. The primary endpoint is overall survival, and so the trial is not ended, so I cannot tell you the answer because I don't know the answer. Secondary endpoints are also being collected, which would include quality of life, safety, tolerance of the regimen. These are good questions. I don't know the answer right now. We hope to have that answer soon.
Now, we know